Welcome, everyone. Good afternoon here from Portland. I'm Dr. Vijay Yadav, the neurologist as well as the director of the MS Center at OHSU. And we are very delighted to present to you our talk today, which is on COVID-19 vaccines and multiple sclerosis. And I'm very pleased to invite a very special speaker here with us, infectious disease doctor, Dr. Marcel Kerlin. Who will be giving us the insight about where we are in terms of briefly about the disease itself and also mostly about the vaccines. So before I go further, I would just remind the audience that for any question that you have, email Dawn Christensen, and the email is right here, and I think you have that on your registration as well. And I also want to thank Biogen for providing the support for this program. So as I said, I am a neurologist, MS doctor, and I direct the MS Center here. I also serve as a neurologist at the Portland Medical Center. So we have a ton of experience with patients that we are seeing on a almost everyday basis here on MS. And of course, since the COVID pandemic arrived, we've been fielding all kinds of questions. So I think I would be mostly sharing our practical knowledge, what we have been recommending, and of course what we are learning from the experts around the world. So I would now like to invite Dr. Kerlin. Dr. Kerlin is an associate professor of medicine in the Division of Infectious Disease at OHSU. He did his undergrad degree from Amherst College, did his medical doctorate degree at OHSU, and then did his residency at University of Utah, and did his fellowship at the University of Washington. He's an expert in molecular virology, HIV vaccine study, and he's been directing a lot of the COVID vaccine work and COVID management at OHSU. So I'm going to let him take it away from here. Dr. Kerlin?
Vijay, thank you so much for the kind invitation and the very kind introduction. So let me see if I can share our my slides. Happy to talk a little bit about COVID today. I have a few slides on kind of the background of COVID, and I'll go through that rather briefly, and then maybe dwell a little bit more on some of the vaccine slides, since I think that many people have questions about vaccination, and that's such a prominent issue that's on everyone's minds right now. And a lot of personal decisions and public health decisions to make around that issue. So hopefully we'll set the stage with a few comments first about COVID virology. So this is, the world woke up to COVID in December of 2019 when a cluster of pneumonia cases emerged in Wuhan, China. This is the night market in Wuhan, China. Seemed to be centered on this, and very, very quickly from there, from this isolated cluster of cases that really no one was aware of except for local health officials, what emerged from that was this terrific explosion, this epidemic that became a world pandemic. This is a brief timeline showing incident cases. On the left is the large blue arrow on the left shows the very first cases of pneumonia in China before the turn of the year. And then you can just see this rapid global explosion, really. The blue area is showing Asia, and then Europe in yellow, North America in orange, and South America in green. And you can see the areas that have been hit the hardest. Some grim milestones, 1 million death toll in around October. Right now in the United States, a very large number of people have unfortunately passed as well. And then a more hopeful milestone with the advent of the vaccine, multiple vaccines that have just started to get out into people at the end of 2020. Where is COVID happening? This is a map of the world with dots representing the size of the epidemic. And what's notable, these are reported cases, of course, and maybe there are a large proportion of unreported cases in some places. But you can see that North America and South America have been hit rather hard, as well as Europe. likely reflecting travel, travel patterns, etc. So this is truly a global pandemic. Consider for a moment 28 million cases in the United States and 493,000 deaths as of recent count. That's more people than have died in World War I and World War II combined, in American casualties from the two great world wars combined. And of course, on the world stage, the numbers are that much larger, and it's just a reminder of the severity of the epidemic. Okay, well, what is COVID? This is the world of viruses that affect humans, broken up into the different categories. It's not something to remember except to consider that there are many, many different kinds of viruses. COVID is an RNA virus. It's a coronavirus. It's in the 7 o'clock position on this round diagram on the right, showing all of the families of viruses. It's called a coronavirus because of the shape. It's got these knobs on the surface that look like, make some people think of a crown. Coronavirus, SARS-CoV-2, coronavirus 19, the etiology of COVID-19, is related to other coronaviruses, some responsible for relatively minor infections in people, and then also other coronaviruses that have been responsible for smaller but somewhat deadly epidemics, including the SARS epidemic in Hong Kong and the MERS-CoV epidemic in the Middle East. This one has dwarfed the others by a large margin. SARS-CoV-2 is considered to be a respiratory virus, so infection occurs typically through the mucosa of the respiratory tree. And then this slide depicts the cascade of inflammatory and pathological effects that happen after that. In the middle of this diagram is an alveolus from the lung, and surrounding it is a blood vessel, and depicted are many of the interactions and inflammatory pathways that get activated. Transmission is thought to be from droplets, but also possibly in small measure from fomites. There's a question about airborne transmission and oral fecal transmission as well. So as a respiratory virus, COVID-19 has typical respiratory symptoms. You see a normal X-ray in the center, and then an X-ray, a chest X-ray from someone who's suffering from severe COVID on the right, and the obvious abnormalities that are disseminated throughout both lungs in this unfortunate individual. It's typically manifested by, it can be frequently asymptomatic infection. So 40 to 45% of people have no symptoms at all, maybe not even aware that they're infected. But in those who do have symptoms, a viral syndrome with headache, fever, chills, muscle aches, etc. There are often symptoms of upper respiratory tract infection, and then in those that go on to severe infection, often severe respiratory impairment. This slide looks complicated, but there's only one point here, and that is that during a viral infection, the virus has receptors that dictate which cells it can infect, and also has to do with the immune responses. Which cells a virus can infect dictates tissue-specific dysfunction, and tissue-specific dysfunction dictates disease expression. So when we talk about all these complex host cell receptors that viruses have, that's really what underlies what disease looks like. And in the case of COVID, one very prominent thing is that the virus affects blood vessels. This was recognized a little bit later. It was initially considered to be a respiratory virus primarily, but with the recognition that blood vessels are affected, among other things, and the fact that blood vessels affect every organ in the body, we've moved to an understanding that not only is COVID-19 a respiratory virus, but also a vascular pathogen, and therefore has multiple manifestations, many of which you see here, and which I won't go into in any detail, but we all understand that COVID causes many, many effects beyond just respiratory impairment, which can be quite severe. Factors associated with mortality, of course, not everyone dies from COVID. Many people have asymptomatic infection. The vast majority of people have mild disease, but then some people have severe disease. And there are some laboratory findings that would suggest severe disease. We also, so these are markers of inflammation. abnormalities of the immunologic system that become manifest after infection, elevated neutrophil percents, elevated D-dimer. These are laboratory markers. Evidence of kidney infection, liver infection, which we can see in laboratory tests. And then clinical prognostic factors. So not everyone is equally susceptible to the bad effects of COVID. Men have a worse time than women. If you're older than age 65, you're at higher risk. Those who smoke cigarettes or have underlying conditions such as hypertension, respiratory disease, diabetes, cardiovascular disease, and obesity, those individuals are much more likely to experience the severe effects of COVID and are largely responsible for the severe cases that we see in the hospital and in many cases death. So this is kind of shows the pathologic events of COVID. If you follow this circle from 12 o'clock counterclockwise, we see this infection of epithelial cells, infection of alveolar macrophages, activation of the immune system, and then finally, as we complete the circle, severe end-stage organ disease. And I'll move on from there to just a few remarks about treatment. But so in summary, COVID is a respiratory infection, inflammation, vascular disease, and multi-organ system damage. We can, of course, treat COVID, and I'll go rather briefly through this. Treatment is through antiviral agents and immune modulation. They're the two modalities of treatment that we have. The basic summary is that there's evidence for a few agents that have some moderate efficacy, but there's no real home run drug against COVID. I'll just run through a few. Remember hydroxychloroquine, which was initially thought to be possibly helpful and has now been relegated to likely inactivity against COVID. Remdesivir, which is standard therapy, an antiviral created by Gilead, originally for the treatment of Ebola, and does help to some extent, but really does not eliminate disease. The effect is measured in large numbers of people with slightly reduced hospitalizations and perhaps lower mortality rates, but is not a home run by any stretch, although it has become standard therapy. There are a few other investigational agents that people are considering among direct antivirals, and then agents that are supposed to modulate the immune response. So part of the problem with COVID, as I mentioned, is that people get infected, but then the immune response is what really can be deadly. So if you can imagine perhaps a fire in your home, you have a small kitchen fire, and one objective is to put out the fire. But if the fire department comes with huge huge high pressure hoses and continues to blast your house with water after the fire is out, then they're doing more harm than good. And that's in a way an analogy for the immune system. If the immune system is overly exuberant, the virus may even go away, but what we're dealing with is the downstream complication of inflammation. And so some agents are designed to treat the inflammation itself. So they're not antiviral, but they're treating the after effects of the infection. I've just shown you a few. The one that I'm showing you here is tocilizumab, which is a monoclonal antibody against IL-6. It's the one that's probably the most well recognized now as being mildly effective against severe COVID disease and is now being used in many places. There are also monoclonal antibodies against COVID. So I'll go over the rest of these. There are a few other approaches like convalescent serum and a few other things like mesenchymal stem cell transplants. But in general, there are many many agents that are simply not effective, although many have been tried. With that, I'll mention the last thing, the optimal approach, which is probably antiviral therapy early on during infection and then immune modulation afterwards. But what about prevention of infection? So that's for people who have been infected. But what about trying to prevent COVID infection, people who are not yet infected but who are at risk, and particularly those who are at risk of severe disease? We understand that masks and social distancing are critical cornerstones of our ability to prevent COVID. And that can't be overemphasized. As part of occupational health, I see the effects directly of mask use and appropriate PPE use and distancing on our population here at OHSU. And I can tell you that the masks work, and masks are preventing infection and they're saving lives. So I'll mention that and underline that. Another very important part of our armamentarium is vaccines, and those hold out terrific hope for really bending the curve of the epidemic. So let's talk a little bit about COVID vaccines. As you look at this, maybe some people can guess what this picture is about. I'll give you a moment to think about it. There's a picture of a person, a portrait on the left, and a photograph of skin on the right. This is Edward Jenner in the 1700s, and the skin photo is an example of cowpox. And he was the first one to recognize that cowpox exposure, which was a mild illness, could prevent against smallpox. And that was really the dawn of vaccination in modern science. This is a picture of Louis Pasteur, who finally figured out, he figured out by accident the idea that a weakened pathogen could protect against the full-strength organism. So he was working with chickens, and he had a bacteria that would routinely and reliably kill chickens. He was interested in bacteria. And one of his laboratory assistants left a culture out by mistake. Basically, the assistant screwed up and then was going to inoculate the chickens with this bacterium, but used a weakened, something that had been left on the bench for a long time. And the chickens didn't get sick, and they recognized their error, and then inoculated the chickens with the regular full-strength strain. But lo and behold, those chickens were protected from infection. That really ushered in the era of vaccines. And what happened after that, these were some key conceptual advances, recognition that diseases caused by microorganisms and pathogens can be weakened by a variety of means to provide a memory immune response. What happened in the couple of hundred years after that was an explosion of vaccines using this principle. This is a timeline showing Edward Jenner on the very far left side with the smallpox vaccine, and then a little break in time, and then this explosion of vaccines for various conditions in the years since then. It's really a remarkable achievement and a testament to the progress of science. So do vaccines have an effect? Yes, they really do. This is a diagram showing various diseases, including from the top to the bottom, mumps, hepatitis, rubella, chickenpox, measles, which is the larger one there, hepatitis B, and a few others, including polio and diphtheria. And what you're seeing is a series of circles that represent the toll of the infection, of a given infection on the human population in terms of number of cases, and we have mortality. And what you see is the orange circle is when the vaccination against that disease was introduced. So as you go from left to right in time, you can see that the introduction of the vaccine has resulted in terrific reduction in cases for all of these important public health, these important diseases that are important from a public health perspective. So it's a really remarkable and dramatic correlation between the introduction of a vaccine and disease control. To understand vaccines, you have to have at least a basic concept of immunology. So I'll show you one slide. You don't have to remember any of the details, but I'll give you the main point, which is that at the top of this slide is when we get exposed to some kind of a pathogen. It's that red thing up there. In this case, that's a COVID virus. And a couple of things happen in that response. So on the left side, the exposure results ultimately in B cells, which can become all the way down on the bottom left, either memory B cells in the case of when you want to have long-lasting immunity, or plasma cells, which are supposed to be active during the response to the disease itself. The plasma cells release these antibodies, and antibodies in your blood circulate and can neutralize the virus. On the right side is the other half of the immune system, which is the cytotoxic T cell response. And that side of the immune system recognizes and kills infected cells. So it's not directly attacking the virus in individual virus particles, but removing cells that produce virus. There are two complementary limbs of the immune system that work together, and the way they get educated and primed is through a system which goes down the vertical side of this, the midline of this slide, just showing exposure and then a system of antigen capture and presentation and immune education that happens within our immune system. So just remember that there's an antibody side and a cellular side. They both rely on exposure followed by education, and then they have this memory response that protects you against subsequent infection. So the question is, how do we make the immune system respond and be ready for COVID without getting COVID? All right, the way to do that now with this sort of the tools that I showed you that resulted in all of these new vaccines, what we really have are a couple of different ways that we're using. One is across the top here. You can just take the darn protein and purify it and give it to people. The other way is to trick the body into making some of that protein by itself. And that's pathway number 2 and pathway number 3 in this diagram. So in pathway number 2, what we're showing is that the gene for the spike protein of COVID, that outer knobby thing that gives coronavirus its name and that antibodies can recognize, we're taking the gene just for that one protein and we're putting it in a sort of a Trojan horse virus that's an attenuated, a weakened virus, and then that's our vaccine, and we vaccinate someone. The virus is so weak it doesn't cause any illness, but it does induce a few cells to make that protein, and then the immune system gets a look at it, and the pathways that I showed you in the previous slide get activated. The last thing is the bottom pathway, which is number 3, and that's an mRNA vaccine. So what that is instead of using a Trojan horse virus that contains a DNA molecule, it's just the RNA itself, the downstream instructions to make that protein, typically enclosed in a fatty sort of droplet, like a lipid nanoparticle, to protect the RNA. And that goes into the body, and the body produces the protein. Then the immune system sees that protein, recognizes it as foreign, and then mounts an immune response. What's really the latest here is these RNA vaccines. They're the newest kid on the block, and so I'm spending a few moments to talk about them. They're based on the observation that if you take RNA in a lipid nanoparticle, it could actually enter cells. We first discovered this in the late 1980s, and it's the basis for how we do gene therapy and RNA-based vaccines. In the mid-90s, someone figured out that these liposomal encapsulated RNAs can actually stimulate the immune system. And then 15 years later, with additional progress, Moderna, the company, was founded because they recognized the potential for vaccine production and a quick way to make effective vaccines. Fast forward another 10 years, and Pfizer and Moderna COVID vaccines are the first RNA vaccines approved under any emergency use authorization for use in a disease. So that's really a brief history of how we got to the RNA vaccine concept. What's notable is that it's not a recent thing. It's been around for some time, and so we'll come back to that point a little bit when people ask about the speed at which these vaccine products have been developed. RNA vaccines do have some advantages. Number one, there's no need for exposure to the active infectious agent. It's just the instructions directly injected into the body. And then the RNA degrades and is gone. So there's no lasting effect except for whatever is resulting from an immune response to the protein that's made. The second major advantage is the plug and play nature of this platform. What I mean by that is if you figured out how to make a lipid nanoparticle and you figure out how to put an RNA molecule in there and create a vaccine, when a new infection comes along, you swap out that RNA for a similar RNA encoding whatever the new thing is, and you're already ready to go. So you can rapidly switch from one pathogen to the next using the same platform, and therefore you get a terrific advantage in terms of the pace of your development. Number 3 is there's no DNA intermediary needed. So it's directly RNA, and so it goes straight from RNA to protein, and the RNA is degraded. And you can also switch around the lipid droplet so that it can target different cells. So it's a tunable platform, and that's very important. Disadvantages of RNA vaccines, well, at the moment, they're still rather fragile. They tend to be fragile molecules, and so there's a cold storage requirement. You have to handle them carefully. Agitation can break down some of these lipid particles. And then scale up requires some thought. You have to have massively parallel processes to scale up because they rely on microfluidics for their production. So putting it all together, this is a lot of detail, but basically it's showing the three different ways in which you can have a vaccine: virus vaccines, viral vector vaccines, nucleic acid vaccines, and protein-based vaccines, all of them going into the center of this figure where the immune system captures the antigen, takes it to a lymph node off to the upper right, and educates the immune system. You can see the B cells and the T cells there. That's the immune system being educated. And then your memory immune response, in the end, protects you from future infection. So far, so good. That's the theory. But are these safe? Are these vaccines safe? Well, every time you find a picture of Edward Jenner, kind of vaccinating someone, you see this suggestion that he's working with someone who's not entirely willing. I would say this is one of two things. This is either, kind of the first example of vaccine hesitancy, or you can look at it as, the version of informed consent that happened back in the 1700s. Okay, we have come a long way since these days. When you make a vaccine, there is an incredibly regulated, a methodical, step-by-step proscribed system and pathway by which something goes from an idea into something that gets put into people and then tested in large scale and then finally approved. There are preclinical studies, phase 1, phase 2, phase 3 studies, and post-marketing phase 4 studies. It's a very long subject, and we could spend an hour talking about it, but the main points to take away are that there's this progressive size in the number of people that get involved in these studies. The scrutiny by independent regulatory bodies and scientists is intense and unbiased, and it's uniformly applied to all new products. And we can talk more about that if there are questions about this. So what is now in the pipeline in terms of vaccines? Well, there are 4 vaccines that are either approved in the United States under emergency use authorization, or the approval is likely coming soon. These are some names that you may know: Pfizer, Moderna, AstraZeneca, and Janssen. Pfizer and Moderna are the mRNA vaccines that I talked about before, and then AstraZeneca and Janssen are viral vector-mediated vaccines. They're the ones that are the Trojan horse type vaccines that have an inactivated, harmless virus that then delivers the instructions as a payload. You can see that the storage conditions are much more challenging for the RNA vaccines. They have to be kept frozen. And for well-resourced countries, that's fine. But for a large part of the world, that represents a significant barrier. You can see the regimens that are there. Typically, there are 2 doses, 3 or 4 weeks apart. But in the case of Janssen, it's a single dose. And then how well do they work? Well, they are quite, the information we have is that they are quite effective against preventing symptomatic or serious illness. That these are new results coming out all the time. And these numbers are likely to change. They're based on a relatively modest number of infections, but as more and more people get vaccinated and we understand how it works, these numbers are likely to change. The status is that Pfizer and Moderna are now approved for emergency use authorization in the United States, and AstraZeneca is pending, but is approved in the UK and in the EU. I talked to you a little bit about vaccine efficacy. One recent bit of information that's very important is the second bullet point, which shows that for Pfizer and AstraZeneca, there is indication that not only does the vaccine prevent against serious illness and death, but that it does in fact reduce mucosal shedding or nasal carriage of the virus. And that's terrifically important because it is likely to lower the risk of transmission to others. So not only are you protected from severe disease, but you're by getting vaccinated, you're protecting others around you, your loved ones, and the people that you come into contact with. Where are vaccines rolling out? This is a map of the world, and from light to dark is rising prevalence of vaccination. I think in the United States, we're at 17% coverage. The highest coverage is about 70%, and that's in the country of Israel. United Arab Emirates and the United Kingdom are also very high and slowly rolling out to the rest of the world. So we're actually, although we've experienced a lot of deaths in the United States and a lot of a terrific burden of disease, we're also moving quickly with vaccines. Where are the vaccines going? Well, it's interesting to see the different vaccines and where they're ending up. Pfizer is in these locations. You can see North America, some parts of South America, Europe, and Oceania. Moderna, a little bit more limited, but for whatever reason, so in the United States and Canada, Europe, and for whatever reason, Mongolia. AstraZeneca, more dispersed throughout the world. AstraZeneca is likely to be one of the most prevalent vaccines because it's going to be very expensive and it's effective and it does not require intense refrigeration. So those factors will make AstraZeneca likely be taken up by a large part of the world. And then there are some vaccines we don't talk so much about, produced by other countries such as Russia, China, India, etc. This one here is produced by Russia called Sputnik 5. We're not likely to see it in the United States, but it is being used in some parts of the world. And then there's a Chinese vaccine too, Pakistan, China, Mexico. What about in the United States? So far, we've had about 41 million doses received, and about 16 million people have received 2 doses. There are plans for 100 million doses by the first 100 days of our new administration. And currently, I think we're going to meet that because currently we're vaccinating at a rate of about 1.6 million doses a day. This is the map that shows where coverage is happening in the United States by state. And the question is, at this rate, where will we be? There's a thought that if we can get coverage of 70 to 90%, we'll achieve some degree of herd immunity, meaning that people will be protected from infection to some extent just because there are fewer people around them that are susceptible and likely to give them infection. And so that's the state of herd immunity. And at this rate, we're going to hit between 70 and 90% somewhere late in the year. So that's an encouraging statistic. The last few things I'd like to mention, what about these SARS-CoV-2 variants that we've been hearing about? So this is a sobering development. It's a predictable development. Viruses replicate and make mistakes as they do so. And if you have enough people who are infected, you're soon going to, the combination of mistakes and a large number of people who are infected and producing a large number of viruses, those factors fuel the process of evolution. So very predictably, the virus is going to change and take advantage of any new opportunities. The first new variant that was noted to circulate in high levels was the B.1.1.7 in the United Kingdom. That happened in the fall of 2020. The next one was also in October of 2020, a new variant seen in South Africa, the B.1.351 variant. And then finally in January, we saw a variant called P1 in Brazil. And these are now spreading rapidly throughout the world. The reason they're significant is, number one, their widespread dissemination and the large number of mutations, the large number of changes in the genetic code of these viruses. And those raise the possibility, which in some cases has been observed, of heightened transmissibility and possibly escape from either natural immunity leading to reinfection or escape from vaccine-induced immunity. So the fear is that you get vaccinated, but then exposed to one of these variants, and therefore you can still get infected. It would it would seem at the moment that the current crop of vaccines will provide some protection from the current variants that are happening. But eventually, there will be strains that will likely escape altogether. And my guess is that we will require booster vaccines at some point for COVID, unless we win the race and can really completely eliminate the epidemic through vaccination quickly enough before those variants come up. So we're in a race against the virus. The last slide I'll leave off with is a hopeful slide. It goes back to the image I showed you earlier of these many different diseases that have been controlled by vaccination. And my fervent hope and expectation is that as we get vaccines out and we have an effective vaccine rollout against COVID, we will see the epidemic shrink down to small numbers and ultimately be controlled successfully. So that is the future that, the hopeful future that we're heading towards if we're successful in vaccinating enough people against COVID, and if need be with boosters over time to take care of circulating variants. So I'll stop there for now. That was my last slide, and turn it over to the organizers, and happy to take any questions.
Thanks, Curly. Can you hear me?
Yes.
So I'm going to start my presentation. Thanks for a wonderful overview. That's really, really helpful, I think, because it'll build, where I'm going to start. All right, so I think I'm going to switch gears here, and after this overview of the vaccines in general for COVID-19, I'll talk more specifically about MS and what we have seen so far from data around the world, as well as what the guidelines are saying about use in MS patients. So that's what I think this next segment is going to be talking about. As Dr. Cullen mentioned, that not everybody who gets COVID is affected significantly. So this is a cartoon showing like this is gray, like people they are uninfected. Virus comes, and then within, like, let's say if there are 100 people, and within the 100, there would be 80% or more who would not be actually affected significantly. They could be asymptomatic. They could be having very mild infections, and then there would be another subset of people who could be more sick. They may be hospitalized, but they may not need intensive care. And then there are unfortunate people who will really become extremely sick and they will not really make it. So severe disease is not a big part, but at the same time, it is extremely concerning that has to be addressed. And we need to understand what are the factors which makes one person have a severe disease versus another who does not really get the disease. And while we're learning a lot as this pandemic has come, we still have a lot to learn at this time. And what we have learned so far is age, gender, and comorbid conditions. I think they're really playing a big role in a person having severe disease. So specific to MS, the studies have been happening since the pandemic started. Many of them have been published. Some of them, these are still kind of small numbers which are published, but this one study looked at specifically MS patients and what are the factors. And it's very similar to what we are seeing for high risk of complication that is seen in the general population with COVID. Similar things are seen in MS population as well. So what I show you here is the role of age and gender, which of course nobody has control over. So you have higher age. So people who are more than 50 and older, they tend to have higher risk of complications, especially as you get above 70 and above, it's much higher. And then somehow the male gender is affected more than a female. And the figure on the right side shows the role of race and ethnicity. And unfortunately, for some reason, again, not very clearly understood at this point, but people who are non-Hispanic, American Indians or Alaska Native or Black or Hispanic Latino, they tend to have a much higher rate of complication. So this study was published recently, and this is coming from a group of hospitals in France. And what they have done is they have this whole network where people or the doctors are reporting the outcome of these MS patients who got COVID and what the outcome was. So what they have found, this is about like 300, this is about 200, actually 350 people or so that they looked at, and what they found, so age, gender, comorbid conditions, they remain as high risk factors for complications. Specifically within the comorbid conditions, people who have cardiac disease, lung disease, especially diabetes and cardiac are like the top two conditions which are like, adding to the high risk of complication. And within MS population, as you know, our patients have neurological deficit, and many of them have significant impairment to walking or other limitations. So people who have very high level of disability, neurological disability, and EDSS of 6, EDSS is, many of you may know that it's a score which assesses the neurological disability in MS, specifically in MS subjects, with the 0 being like no disability, 10 being a person is dead. So a person who's like 6 or higher or 5.5 or higher, they tend to have more difficulty, especially with ambulation. So EDSS of 6 would be a person with MS who is requiring a cane or support to walk. So you see here, person who are people with MS who are requiring assistance, they tend to have the highest risk. One of the highest risk odds ratio is the risk of somebody getting more complications. So as you can see, the number is really high, 16 times. They're 16 times higher than the person with lower risk, lower disability. Sorry. Again, the progressive MS, MS, as you know, is of different subtypes. The most common is relapsing remitting type. And then you have the progressive disease, which can be either secondary progressive or it can be primary progressive. So MS patients who have progressive course tend to have higher chances of complications from COVID. One thing which came out of this study was the role of disease-modifying therapy and whether it was adding to the risk, or was it how was it playing with the risk of the COVID? So the good thing that they found was, if you look at the disease-modifying therapy, and we'll go in more details in the subsequent slides, the disease-modifying therapy actually are not adding to the risk of having complications from COVID. It is, in fact, probably causing lower risk of complication, in our MS populations. And so these are different factors. When you're doing analysis of such a huge data, you need to do some corrections. So this is univariate analysis, which sort of just showed what the top 10 or 15 risk factors were, but then you put that in a different model, and then you see which one is most significant. So it looks like when they did this multivariate analysis, the factors which were still very prominent were, again, high disability level. EDS is more than 6 was still coming out to be high, and again, obesity, cardiac comorbidities, and age and gender were also really important. So I'll just give you an overview of the MS treatment landscape right now, where we have more than 20 disease-modifying therapy approved for MS. The first ones, they came in early 90s. The first ones, they are called platform therapies, such as interferon beta-1A or beta-1B. And then glatiramer which also, these are all injections. And then came the oral therapies starting in 2010 with fingolimod as the first one. And then subsequently, we have had several of them approved. And then we have high efficacy therapy, which are mostly infusions, whether it is natalizumab or Tesabri, or most commonly now we are using Ocrevus. And then alemtuzumab is another infusion. So we will see what is the evidence for use of these therapy, what is the risk, that these therapies may or may not bring. So the same study which was looking at the disease-modifying therapy and if we had any role in the risk of complications. So this is a graph where the patients are grouped by the severity of outcome of the infections, COVID-19 infection. So one is that the subjects were, or the patients were not hospitalized, they had no limitation whatsoever, but they were positive. So these are all positive patients who were tested by PCR for the COVID virus. And then 7 is that they died because of COVID. So what you see here is a gray bar on the right is basically MS subjects who were not on any treatment. So what you will appreciate here is, unfortunately, many of the people who died who were not on disease-modifying therapy. So that seems to make the sort of, among the people who died, seems to be the highest type of population who was not on disease-modifying therapy. And when you look at drugs such as interferon, glatiramer, teriflunomide, it seems like they are not really having any significant risk of complications. the drugs that we were thinking or hypothetically were thinking that are high efficacy, and because they are affecting the immune system in a more apparent manner, they may cause more complications. So drugs such as ocrelizumab, rituximab, which are antibodies against the CD20 molecule, and then cladribine and emtricitabine, which are also sort of more immunosuppressant. So far, they are not really seeing any high risk of complication with these therapies. And this one in particular, there was just one hint that maybe rituximab, which is, so 7, as I said, is like the patient with MS who have they died or they had very bad outcomes. So 6 and 7. So among all of the therapies, which rituximab was probably the highest one with a mortality rate of close to 4%. However, the numbers are very small. These are subjects, again, in like one country or like a group of different hospitals. So I think we need to wait for larger data and probably more like, well-controlled studies to really make a sense of that. So keeping this in mind that anti-CD20 therapies could have impact on the COVID complications, we did modify our practice of how we are treating our patients. So from March of 2020, when the first kind of COVID patients and when we started to see, and then April onwards, we did start, and we were getting the information from other countries such as Italy or Sweden or France. All of these countries were, or Spain also, so they were reporting data ahead of us. So we learned from them, and then we did modify some of the regimen of the infusion, when it should be given, or can we postpone it, or can we hold it. So we did modify our regimen during that time. So this, so in the next session, actually, what I'm going to show you is all of the disease-modifying therapies when they're approved by the FDA. FDA requires them to do studies with vaccine, but because vaccine safety is always a concern, and how the impact of a particular drug could be on the vaccine is always an important question. So those things are done. So next subsequent slide will just give you a glimpse of different disease-modifying therapies which have been approved, and the different vaccine studies which were conducted to show whether or not the vaccine could be effective. So, for example, teriflunomide or Aubagio, and I'm going to use the trade name here because many of you probably know the trade name more than the generic name. So this is a cartoon showing the impact of influenza vaccine response in a person who's getting Aubagio or teriflunomide. So the two dosage of teriflunomide, 7 and 14 milligram, were tested against person who was getting interferon. And what you see here is there's no difference between the impact or the efficacy of the antibody titers, the influenza antibody titers, in response to the vaccine. So this particular thing is reflected in the prescriber information or the FDA approved indication that influenza vaccine is safe to be taken in patients who are getting teriflunomide. So similarly, rabies vaccine has been tested, like TB tests have been done, and they didn't really show any difference in people who were on placebo or meaning the non-active drug versus the teriflunomide active drug. There was no response difference between the two groups with these vaccines. So another example is dimethyl fumarate or Tecfidera, as many of you commonly know. So this is comparing the response to different vaccines such as tetanus vaccine, a diphtheria vaccine, pneumococcal vaccine, meningococcal vaccine. And if a person who's on Tecfidera takes these vaccines, what will their vaccine response be? Can they mount enough response or immunity to the vaccine in response to the vaccine? So this is showing that if you compare, so the control group here is people who are taking the interferon. Interferon are not considered to be affecting the vaccine efficacy for any of the vaccines. So they don't really see a difference in tetanus or pneumococcal, meningococcal, or diphtheria or pneumococcal between Tecfidera and interferon. So this gives us a sort of, kind of satisfaction that, hopefully the COVID vaccine also will behave the same way. The vaccine studies the COVID vaccine studies have not been done any of the disease-modifying therapy as yet. They are in either planning phase or in the beginning phase, or like in the early phases. So I think the results have not been out, but hopefully in a few months, we may get more data on that. This is another drug, natalizumab. Many of you are very familiar to Sabri, and how it impacts, or how it could impact vaccine response. So this is example of a vaccine which is basically called neoantigen, and they did not really see any difference in the response to placebo versus natalizumab on this particular vaccine effect. So this will be reflected, I think these findings will be reflected in the guidelines which are published, which we'll be talking in like just a few minutes from the National MS Society. Another thing that people are commonly asking, like, that I am on these drugs and like my cells are down, and how can the vaccine impact? So while we don't really have perfect measures to see how the vaccine could be effective, such as like, level of immunoglobulin, whether it's G or M or different subtypes, these are not really as well understood, but we do know the impact of Tisabri on different immune cell types, such as like T cells or B cells, and what we know is if you give one dose of Tisabri, whether it's a T cell or a B cell, they will go down. They will change. I won't say go down. They will change, and the impact on the immune cells can last up to 8 weeks for sure. And then after that, the cells, they start to come back to the normal population in the bloodstream. So this figure talks about how ocrelizumab, and this is a very well-designed study which was looking at the impact of ocrelizumab on different vaccines. So they tested different vaccines, which included influenza vaccine. It included, I think they were looking at a neoantigen, which is also testing that vaccine efficacy. What they are seeing here is if you, so the B cells, they are responsible for production of immunoglobulin G or M. They are the products of B cells. And since the ocrelizumab or rituximab, it kills the B cells, there will be decline in the titers or the production of the immunoglobulin. So can that be impacted when you're giving the vaccine to a person? So because one of the responses to the vaccine is immunoglobulin production specific to the vaccine, right? So I think, this particular study, which is called Veloci trial, it tested in response to an antigen, or a vaccine antigen here. Ocrelizumab does decrease the immunoglobulin. However, even though as compared to the control, which is either taking interferon or they were not on any disease-modifying therapy, the response is attenuated. So the immune response to the vaccine is attenuated in ocrelizumab patients. However, even though it's attenuated, the response is still adequate enough to mount or to be able to be protected. So that's what I think we have learned from the trial which were published last year. So again, hoping that the same thing will be seen with the COVID vaccines as well. And this diagram just shows you, when you give ocrelizumab or B cell therapy, what happens to the B cells which are circulating in the blood. So with a single dose, by 2 weeks, pretty much all of the B cells are gone. And it takes time. It's a gradual increment of the cells which come back in the bloodstream. So by 24 weeks, many people actually will remain completely depleted. There are very few who will replete, but I think by the time it can take 9 months, sometimes 12 months or so for the cells or B cells to come back to normal. So that's one of the concerns which was driving our decision to adjust the dosing of ocrelizumab in patients who, because we did not know how, if they got COVID, how they would respond, or now the question is if they get vaccine, how will the vaccine respond? So we will now switch to another drug, and then we'll talk about the recommendations which are given by the National Society about how to handle this situation. Mavenclad is another drug which is also quite potent. It is probably in similar efficacy to, so between fingolimod group of drugs to ocrelizumab, CD20 molecules. So, but it also impacts the E and T cells significantly. So, and this will be reflected in the recommendations also. So what you see here, after you, cladribine is given in sort of once a year regimen. 2 regimens are given and they are 1 month apart. But it does decrease the cells. So we have to time the vaccine, if possible, according to where one is in terms of the immune cell population. So these are the guidelines which just came, I think it's been like maybe a few weeks now. It was endorsed by all the different organizations which are really playing a key role in MS management, whether it's consortium of the MS centers, whether it is the ACTRIMS, or whether it is International Organization of MS Nurses or MS, the Society of Neuroimmunology. All of these different organizations have really wholeheartedly supported that people should be, MS patients should be vaccinated, and the disease-modifying therapy, how we can modify it. So first of all, as Dr. Curlin said, these vaccines are safe, and absolutely in MS also, these vaccines will be safe, even though we do not have MS-specific studies yet, but we believe based upon 40,000 plus patients who were tested in the Pfizer study, these vaccines should be safe and effective. But of course, you should definitely talk to your doctor about when is the right time to get the vaccine. And then we also know the risk of the COVID-19 vaccine is actually worse than the risk from vaccine itself. So the disease versus vaccine, I think we need to choose the vaccine for that. Right now, because there is a kind of rationing of the vaccine, but once it's available, I think members of the same household or close contact, they should also be vaccinated against the virus. And I think I'm not going to belabor this point because Dr. Cullen already mentioned this. These, especially, we are talking mostly about the mRNA vaccines which are already approved. So I'll be talking mostly these recommendations for the Pfizer and the Moderna vaccines. And these are not live virus, and they will not cause COVID disease. And another thing is the vaccines are not likely to trigger MS relapse or worsen the chronic MS symptom. However, when you get the vaccine, it is possible that you can get mild side effects, which could include a fever. And when MS patients, they get fever, you can have the same symptoms that they were suffering from before. They can tend to exacerbate temporarily. But usually within 48 to 72 hours, things will be improving and they should be back to normal baseline. So I think the next slides will just talk about specific disease-modifying therapy and what we are recommending. So the way I have put the slide together, interferon beta-1 and the whole group of drugs, whether it's Avonex, Betason, Extavia, Plegridy, that with all of them, or Copaxone, or Glatopa, or glitteram acetate, they are all considered very safe, low-risk medications. Teriflunomide, I already showed you the data that in general vaccines are very safe. Then fumaric acid also similarly considered to have no significant impact on the vaccine effect, and natalizumab as well. So the recommendation is if somebody is going to start, there's no need to delay the treatment. If you're going to start the disease modifying, there's no need to delay the vaccination. You can just go ahead and get it anytime. And if somebody is already on one of these drugs, again, there's no need to adjust the timing of the disease modifying therapies. Okay, so I think this is probably and this information is also on the National MS Society website. So if you have more questions, you can definitely go to that website and read that. But the bottom line is that we do not, at this point, we're not recommending any adjustment in the disease modifying therapy administration for this class of drug. So the next class of drug is S1P molecules, or the drugs called like fingolimod or siponimod or ozanimod, all these drugs, namely gilenium, and zeposia. If you are taking these drugs, then also we are, if you're already taking the medication, if it's ongoing treatment, there's no need to change anything. Just get the vaccine as soon and whenever it's available to you. If you're starting the drug though, let's say you're supposed to start gilenium another few weeks or so, and you have the option to get the vaccine at the same time, we would recommend that you get the 2 dosage of vaccine at least 4 weeks prior to starting the disease-modifying therapy. Okay. So I think that's something to keep in mind, because it can take up to 4 weeks after the second dose of the vaccine for the effect to be maximal. But that's a recommendation. And then if there's urgency in starting the disease modifying therapy, for example, somebody is having really active disease and they really need to start, that needs to be addressed by the physician. So the true drugs, other Lemtrada or lemtuzumab and Mavenclad or cladribine, they are the ones which can suppress the immune system for longer. So they can affect both T cells and B cells. So if you are a new start, meaning you're planning to start these drugs, again, finish the vaccination if you can, and there should be at least 4 weeks time between the second dose and the starting of the disease-modifying therapy. And if you're already on the drug, it depends upon when did you get the Lemtrada. Usually, they will recommend that after you completed the course of the Lemtrada or Mavenclad, wait for at least 12 weeks. Ideally, wait for 12 weeks or longer, so that you have kind of circulating immune cells to be able to help you generate the immune response against the vaccine. So, but we also understand that MS, if it's very active, these recommendations may not work. So you have to work with the doctor. But given a choice, if there's no other better choice, it's better to get the vaccine and then go with the regimen. And then Ocrevus, the for new starts, so this is sort of a diagram because it's for maybe simplicity's sake. The infusions are every 6 months. So what we are recommending, if you are starting the drug new, finish the vaccination at least 4 weeks prior to your start of the drug, and these will be the true dosage, which are based upon which vaccine is either 3 weeks or 4 weeks apart. And then the next, and so that's good. Sorry, that will be your new start. If you're already on the infusion, if you already have infusion going on, try to delay the vaccine again by about 12 weeks or more to be able to get the vaccine. However, again, if there is a patient who's very active, who has very active disease ongoing, we can adjust because disease control is also important than the vaccination. So I think those decisions have to be made very carefully in consultation with your neurologist. Kesimpta is another CD20 molecule which is given subcutaneously. It is every 4-week regimen. So we also have to time the vaccine accordingly. So if you're a new start, then again try to finish the vaccine before you start the drug, if time allows. If not, if you're already on Kesimpta, try to have at least 4 weeks from the last injection to be able to get the vaccine, and then we have to time it accordingly. And we can clarify this more, maybe in the discussion, or talk to the doctor, and they can tell you exactly how to time the vaccines. So, and the last thing about the medication that we use for MS is a steroid. The good thing is we are not using as much steroids now because the use of the disease-modifying therapy has really decreased the relapses significantly. So, but there are patients who may require steroids. So our recommendation is that if you are getting the vaccine, wait at least 3 to 5 days after the last dose of steroid to get the vaccine. So I think I'm almost towards the end of my slide here. So in summary, we have seen that high-risk patients, like MS patients who are getting COVID and are having complications, they have the same sort of risk factors which are seen in the general population. And yes, it is absolutely okay to get the vaccine when it's available. So in conclusion, I would just say that the MS-specific studies, they will be happening. All of the drug companies, they are planning or they've already started planning for the vaccine studies to be happening with the COVID vaccine. And I would strongly encourage all of you to take part in the research if you can, because that's how we learn and we advance knowledge, and then we help others. Vaccine is safe and effective. Yes, as Dr. Curlin said, we do not know the long-term effectiveness. So at least this week, this month, we are saying continue with what the recommendations are, but recommendation could change as the time goes by, which we have seen in the last year. And of course, beyond vaccination, definitely try to prevent spread by wearing a mask, social distancing, and washing hands. because the more effectively do that, I think the sooner we will be able to get rid of this menace that we have right now. So with that, I'm going to conclude, and I think I'm going to ask Dawn to come in.
All right, hello. So we did receive a lot of questions for the program, and so I'll go ahead and get started. And it looks like you guys addressed quite a few of the questions, but there's some that sounds like they kind of want clarification on. So I'll go ahead and get started. One question we had is, are the first and second doses of the vaccine basically the same thing? But the second dose is one that kind of brings up the levels that would kick in the fight against the virus?
Yeah, so the first and second doses are indistinguishable for most of the regimens, most of the vaccine products that are out there.
Okay. And then someone had read a third of the people get a reaction to the second dose of the vaccine. Is that a sign, a good sign that the immune system is working like it should? Or if you don't get a reaction or side effect, should you be concerned that your immune system isn't working quite like it should?
Symptoms after vaccination are generally an indication of immune activation, but we don't have any information that the severity or lack of symptoms affect your immune responses in any way.
Okay. And then, and you, Dr. Yadav had kind of touched on, there's a lot of questions, of course, about disease-modifying therapies that affect the T and B cells as far as reduction. With that in mind, how much protection are the vaccines going to be for that individual? Do you think they'll still be as effective as you had said, Dr. Kurland, earlier, as far as the two vaccines were over 90% effective? Do you think it will be a little less effective? How effective do you think the vaccines will be?
So I think I showed the data on different disease-modifying therapy that we have, and of course, a lot of it is assumption. The studies have yet to be done. The COVID vaccination in MS and DMTs have to be done, and all the companies that I know of, they are planning to do these studies. But at this time, we believe that they should have similar efficacy as other vaccines have had in the past.
Okay. And then has the mRNA vaccine been used on autoimmune disorders like MS before? Is there a history of it?
Not to my knowledge.
Okay. And then what, you talked a little bit about the effectiveness of the kind of, well, the different vaccines that are currently available, the two main one, Pfizer's and Moderna. What is the absolute versus relative effectiveness? Is it the same as what you had mentioned? Is it different?
Dr. Kurland, do you want to take that?
Are we talking about effectiveness in people with MS? Is that the question?
Yeah.
Well, the problem is that effectiveness is measured in randomized controlled trials in which they count the number of cases and then look to see which ones got placebo and which ones got the vaccine product. And obviously, if the two groups look the same size, there's no efficacy. And if the vaccine group didn't get any infections and the placebo got all of them, that shows a high level of efficacy. But you need numbers for that, and those, it's still early. We don't have those kinds of data specifically in these special groups yet.
Okay. And then, so do you, if you feel, as an MS patient, if you feel like you're having a exacerbation, should you still get the vaccine if you're scheduled to have one?
I think I would definitely talk to the neurologist and let them know what's going on, so that they address what if it's a true relapse. There could be decisions that need to be made about like whether steroids needs to be given or something else. So I would definitely involve the neurologist in that discussion. Yeah, I mean, without that, I don't think so. We should really just we should tell our healthcare providers what's going on.
And then, would it be safe? The vaccine be safe for people that are JC virus positive that you're aware of?
To my knowledge, I think that should not be a problem.
Okay. And then is the COVID vaccine safe if you've had an anaphylaxis reaction to sulfa drugs?
Anaphylaxis is very rare, and it's on the order of maybe 10 in a million. So 1 in 100,000 is a treatable condition. And when you look at the number of people that have had an anaphylactic response, some people have had prior anaphylaxis to other things and some have not. So your history of anaphylaxis is not a reliable indicator of whether or not you're going to have anaphylaxis to any of these drugs. But just to remember that it's rather unusual to have anaphylaxis. It's exceedingly rare.
Okay, thank you. And then as we, in Oregon, as we kind of move through the different groups that are getting vaccinated, there's different questions about, the timeline of the groups. And I know there's some information on the Oregon COVID website about that, but specifically is the MS, if you have MS, is it part of a general medical condition group that has any priority, or do they just go by the age, like what it currently, I believe, says in the guidelines?
So what I know that I think MS by itself is not in the category of high risk, but people who are who have MS and who are disabled, who are living in say care facilities, or I think they will be, or if they're older, so I think they will be followed more like general population rather than MS diagnosed by itself is not in the inclusion criteria to my knowledge. Dr. Cullen, maybe you can correct me if you know more.
Okay, and then kind of going along those lines, if hypertension and or cardiovascular disease is well controlled with medication, is a person still at a higher risk for kind of poor outcomes with COVID?
That's a really good question. The answer is probably yes. It's not just the absolute numbers, but it's the underlying condition that leaves people vulnerable. And so the medications are not a guarantee that you won't have a bad ride with COVID. Okay.
And then kind of along the same lines, if you do have hypertension and are more susceptible to COVID, do you know exactly why that would be, that they would be more susceptible?
Well, some pre-existing predisposing factors involve inflammation. And in some cases, we don't understand the reason why. So why obesity would be a predisposing factor is not clear. And why diabetes should be is not clear. Although clearly both of those have something to do with the vascular system in some way.
Mm-hmm. Okay. And then can being allergic to antibiotics cause a bad reaction? If you were to, should there be concern in getting the vaccine if you've had allergic reactions to antibiotics?
There's no clear relationship between allergy to antibiotics and allergy to the components of the vaccine. If you're allergic to something that's in the vaccine as a component, then you have to be careful.
Okay, and then I'll just read off a couple more questions because I see that we're over time, if that works for you both.
I'm okay.
Okay. So there's, does it matter which vaccine you get? I know there was quite a few questions about, is one better than the other in general, or specifically if you have MS, is the Pfizer, like currently Pfizer or Moderna is the two people can get, is one better than the other? And it's specifically if you have MS?
I mean, to my knowledge, I don't see a difference.
Not to my knowledge either, no.
Okay. And then relating also to getting the vaccine, if you end up getting COVID, or if you've had COVID, should you still get the vaccine? So say you're scheduled to get the vaccine, you end up positive for COVID, you still get it, even if you're asymptomatic or not?
They say that you should wait 3 months and then get the COVID vaccine after that.
Okay, so if you've had it or tested positive for it, I mean, if you tested positive. Okay.
Yeah, wait 3 months after the date of your infection and then get your vaccine.
Okay, and then the kind of final question, because several people have this question, because the vaccine is the works with the RNA. And do you feel like it's more effective than the two other kind? You had talked about 3 different kinds of vaccines that we've traditionally, or 2 others that we've traditionally used. This one is a little bit newer. Do you think that it's as effective or more effective than the 2 types that we had used previously?
Well, the efficacy numbers reported for the RNA vaccines is higher than the other 2 at the moment. I don't know if that's because they're RNA vaccines or if it represents a real true difference between them all, but it's worth noting that these are early data, and a true measure of efficacy for all these vaccines will come out over time as we acquire more experience. I suspect that the numbers may converge a little bit, but at the moment it does look like the RNA vaccines are quite high in their effectiveness.
Okay. All right, and with that, since we're a little over time, I just want to thank you both for speaking, Dr. Kurlan and Dr. Yadoff. And I, really quick before I hand it back to you, Dr. Yadoff, I just wanted to let people know I'll be sending out an email. Thanks again for participating. There's going to be a brief survey. If you would please fill that out, we would appreciate it. And do you guys want to go ahead and close?
I think I will, Dr. Kurlan, you want to say some final words, and I'll just say thanks.
Thank you so much for your attention. I really appreciate the opportunity to chat. I'm happy to respond to questions in the future if people would like to reach out. And thank you so much.
And thanks everyone for joining. And definitely, as Dr. Kurlan said, we need to beat this disease. We need to be optimistic. I know it's hard. Last 1 year has been really hard on many of us, but we have learned a lot. So I would just say, keep up the spirits up as best as you can. Follow the recommendation that the doctors are telling you, the healthcare authorities are giving you, so that we can beat this out. And vaccination is just one of the steps. I think we will hopefully, by fall, we will be definitely in much better shape. That's my hope. And with that, thank you for attention. Bye-bye.
Thank you.